All right, good morning, everyone. As we wait for everybody to connect, let's take a few moments. How are we doing? Does everybody look like they're connected? Almost. Well, good morning, everybody. My name is Desiree Rested. I'm the training developer and manager for the Montana Public Health Training Center. We want to welcome you to today, our very first of the season learning module, and it's going to be a good one. We're going to learn all about the public health wage study that was conducted last year. So with that, we've got 4 wonderful presenters, and I'll allow them to introduce themselves. If you have any questions, please leave that in the chat. And I will be here, Carrie, just so you know, and Lee, I'll have my monitor off, but I will be here.
Well, let me just add my welcome to everyone this morning. It's this beautiful fall morning, and thank you to the Training Center for hosting this presentation. We're excited to talk about the Montana Public Health Wage Study. And let me go ahead and introduce our team here. First of all, I'm Carrie Harris, and I'm a faculty member in public health here at the University of Montana. And I do teaching in behavioral health very broadly. And Lee, want to introduce yourself?
Sure. Hi, everyone. Lee Taggart, and I am an adjunct faculty at the University of Montana School of Public Health, and I'm also the Workforce Program Director at the Montana Public Health Training Center. And maybe, Portia, do you want to go next?
Yeah. Hello, everyone. My name is Portia O'Connell, and I was one of the graduate research assistants working on this wage study. And I just recently graduated with my MPH degree, and I'm currently the program lead at the UM Office of Health Research and Partnership.
Okay. I'll go next. Hi, everyone. My name is Alexis Schmier, and I am a current student in the MPH CHIPS program, and I was also one of the other graduate students working on this project.
Awesome. Thanks, everyone. Just a little more instructions about how to get to know you. If you could add to the chat your name and where you work and where you attend school, so we can get to know a little bit about who's in our audience today. So go ahead and add that to the chat, if you will. And the chat looks like it should be open, and make sure you're chatting to everyone. Oh. Let's see. Great. Good to see you, Todd. Excellent. Oh, so great to see people from county health departments here. Love it. Good. Well, let me just go ahead and talk a little about what we're going to do in our 2 hours together as people are introducing themselves. Oh, so nice to see everybody. So the first hour, we're going to talk about the wage study, some about the methods and results and the key findings. And our goal is to make you an expert on the wage study. And we hope we can do that in the first hour. Then we will take a break. This 2 hours is a long time. And in the second hour, we'll get into smaller groups and talk about how people have used the report or plan to use the report, with the goal of really helping each other out, thinking about how the report can be used, and sharing ideas and strategies and resources. And then we'll talk about those strategies in a large group and wrap up. So let me just give you a quick overview of the wage study. The purpose is really to gather information about salaries from local and tribal health departments. And it's the state health department asked us to do this at the request, I think, of all of you, so that you had information to promote recruitment and retention of your workforce. And the state health department provided funding for this report. And it's important to note that these findings are the study team's findings and not state health department's findings. And one important thing to remember about this study is that we didn't collect state health department salaries. This was really about local and tribal health departments. We wanted to share with you a few of the resources that we found important as we were putting together this study. And we're going to refer to those a few times throughout this presentation. And Alexis, thank you. Just put these actually key resources in the chat so you have access to them. And the first was the Montana Occupational Employment and Wage Statistics Survey that was done in 2022. And Portia is going to talk a little bit more about that. Another was the Council on Linkage's Core Competencies for Public Health Professionals document that I bet a lot of you are very familiar with. And then the Montana Association of Counties did a comprehensive county-wide salary survey in Montana in 2022. And I'm going to share with you a little bit about that report. So this was a salary study done at the county level, so not at the public health level or public health department, but it did include 53 positions, some of which overlap with those positions in public health, like health educator and public health nurse and sanitarian. And of course, there were a lot of other jobs that had nothing to do with public health. And they had very good participation of the counties. So 48 out of 56 counties participated in that salary study. And it includes additional information that we didn't include in our report that you may find valuable, including tax information. And that report was not widely distributed as far as I could see, but it was distributed to participating counties. And now it's distributed to you through the chat. And we found this report, this is a figure from the MACO report. And we found this display of data useful in a model for our study. And one of the things shows the health educator position, and they had 20 employees across the state of Montana categorized in that position, and with 12 counties reporting. And one of the things that we found is that we were able to collect a lot more information from counties and positions. So we reported 88 positions in the health educator category. So while the MACO report is a really good model and it does provide additional information that you might find useful, probably the report that we're going to talk about has a better representation of the salaries in public health. So with that, let's get to the Montana Public Health Wage Study. And that's in the chat. Is that right, Alexis? And I know Desiree sent it out ahead of time, and you may have received it from Todd or others from the State Health Department. So Alexis, why don't you get us started on the report?
Yeah, I did attach that into the chat there. And I'm ready for the next slide.
Oh yeah, that's my job.
Here's the overview of what we're going to be talking about. I'll go over how we created the assessment tool, who we reached out to participate, how we classified the data, and how we followed up, and the summary of what we found. On this slide, you can see the form that we created, our assessment tool, and this was sent out by Lee by email. The information we requested included the following: listing of existing position titles, rate of pay, permanency of the position, if the position was open or filled, if the position had a supervisory role, and if there was program management. The supervisory role data was collected and then later stratified into 3 tiers outlined, and Lee will go over this later in our presentation. And I just wanted to give a big shout out to those that participated in this. We couldn't have done this study without your participation. When our survey went out, there happened to be another survey going out around the same time that was collecting similar data that from what we were looking at. This resulted in some confusion from participants. So there was a lot of follow-up that needed to happen. Follow-up came in a couple different forms, like personal contact from Lee, follow-up email reminders from Portia and myself, and calling to remind them to participate in the survey and answer any questions. Many people responded right away, but others did not. We kept a tracking sheet of all those that participated and when they submitted their survey and how many times we contacted them. And there was also follow-up regarding the completed surveys, like if there was a blank spot or if we needed more information on how to code outside of just the title alone. Our timeline. So this project started in July of 2022, planning and researching for researching other salary studies like the OEWS, which that is in the chat. In October, we've created the assessment tool and did a pilot test with a few counties to work out some kinks. And then from the pilot test, we adjusted and added a few more questions. In November, the survey was officially launched and we started collecting data. We did a few follow-up questions, then ended the survey collection in March. And from March to May, we went through the data and analyzed it and created a final report in July. The survey was sent out to 56 health departments, including tribal. We received responses from 32 health departments and collected 521 public health positions that were then classified into 181 department titles, and then were further classified into 30 different standard occupations. Of the health departments that participated in the study, we received responses from 89% of Montana's large counties, 67 of medium, 57 of small, and 38% of frontier, and 0% from tribal. On this slide, it displays the counties that participated in the survey, and dark blue indicates who participated. Give you a second there to look around. And now, time for questions. Please raise your virtual hand through the Zoom reactions, or put your questions in the chat, or unmute yourself if you have any questions at this point.
Well, Alexis, I think you were so clear that everyone understands the study methods.
I hope so.
So let's turn it over to Portia.
Portia, you're muted.
Thanks. I was afraid that was going to happen. So let me repeat that spiel. Hello, everyone. Over these next few slides, I'm going to describe how we classified the health department positions. But first, I just wanted to take a second to further introduce that OEWS national survey that we used. So this first image is just a snapshot of the OEWS website. And I just want to note that wage data is collected annually from the Occupational Employment and Wage Statistics National Mail Survey, which is conducted by the U.S. Bureau of Labor and Statistics. And then for the purpose of our report, we utilize the Montana Informational Wage Rates by Occupation report, which I think is this next image that should pop up. Yep, right there. And this report summarized the wage data collected from that OEWS survey using the federal 2018 SOC system codes. So I'm good for the next slide. So this image that I have included is just an example of what we saw in part of on our end on the Montana Informational Wage Rates report as we were working to classify health department titles. So as we tried to classify the health department titles, we would look at the health education specialist, which is the title. We'd also look at the description, which is that longer paragraph right there. And then we would also look to the lay title examples as we work to classify each health department title. In some cases, we did have to follow up with health department directors because some of the job titles that we received, we were having a hard time classifying. So we followed up to get a job description to see if we could better classify that and make sure we were categorizing it correctly. So this next slide just shows an example of a few of the SOC titles that we used and some of the health department titles that were categorized into each one. As you can see, kind of looking at this table, some of the SOC codes are pretty broad and they don't capture a variety of the public health department jobs that may exist. You can especially see this with the community health workers, as well as the health education specialists, as there's a variety of different health department titles that were classified, such as a community health worker, WIC aide, WIC nutrition educator aide, and so on. If you look down below here where I have highlighted in the red, I just wanted to take a moment to show kind of how we received some of our health department job titles. For instance, this was one that we had seen a couple of times where it was an environmental health specialist / sanitarian. And we actually had 2 SOC codes that this would fall under. So as a team, we decided to classify these particular positions that would fit under 2 SOC codes into the SOC code that had the highest wage. So in this case, because there's that sanitarian attached to it, we had categorized it in that occupational health and safety specialist because of that higher wage. This next slide that we have shows the top standardized classifications that we got from our report, and then the number of health department positions that we had. So here we had health education specialists and we categorized 88 positions in that. For registered nurses, we classified 77. And then for occupational health and safety, 45. And you guys can all see that, so I'm not gonna read through all of them. Before we move on, I did just wanna take a moment to note that you might not see public health directors or program managers on that slide. And that's because, again, as I mentioned, some of these SOC codes are very broad. So our program managers were classified under that social and community service managers code. And then for our public health directors, they were classified under that medical and health services managers code because there was no specific public health SOC code for either of those positions. Okay. So now that we've discussed how we classified our health department titles, Alexis and I are going to walk you through those top 9 SOC codes that were just on this previous slide and kind of break down the results from our survey. So for this first slide, you're going to see it a couple of times because I just want to take a moment to explain and walk everyone through each of these variables that we have on the tables and our graph. So right here I have highlighted as our average, and the average is just the mean value for all of those green dots that are down there on the graph. And then the next thing on the table that I have highlighted is the weighted average, which is going to be the mean value for all of the positions and their salaries that we received. And then to finish off this top table, we also have the number of positions that we received, and then the number of counties that provided us with information that fit into that SOC code. And then this graph down, or this table down here, just shows the average hourly wage and the number of positions broken down by county size. For our table here, as I mentioned, these green dots are the average hourly wage by county. And then this orange line that we have is the reported mean average from that OEWS report for the state of Montana. So now that I have kind of gotten everyone familiar with those variables on our graph, I'm just going to take a moment to provide some examples of titles that you guys might recognize that we classified in this SOC code. So some of those titles included a disease intervention specialist, a WIC coordinator, a tobacco prevention specialist, a congregate living coordinator, and then a public health educator. And just a few takeaways from this report as we're looking at the table and the graph. You can see looking at the graph that all but 6 of the counties are below that OEWS wage, and many of the health education specialists are located in large health departments. As we see, 62 of the 88 are located in large health departments. And then also, I just wanted to point out that there are some differences in pay by county, but not necessarily how we had expected. For instance, frontier counties were paying a little bit more on average than the smaller health departments for a health education specialist. For our second one, we have the registered nurses, and some example titles that we classified in this SOC code included a public health nurse, a school health registered nurse, a clinic nurse, a community health nurse, and then a registered nurse case manager. And then again, just looking at this table, you can see looking at the graph, all but 5 counties are below that reported OEWS wage. And many of the RNs are located in the larger health departments. And there was also, if you look at the green dots from the start all the way up until the finish, you can see there's a big difference between the lowest paid and highest paid registered nurse, almost being about $20. And I just wanted to see, I'm not sure where we're at on time, but Lee, with your nursing background, is there anything that you want to add to this before we move on?
Yeah, Portia, thanks. So I think one of the important things to note here, and when this salary study was proposed and people were talking about what nurses are getting paid in a hospital, for example, compared to what public health nurses are getting paid. And this is a great example because the OEWS includes all nurses. So that would be nurses in your hospitals, in your communities. So I think, it's a great example of how you can see where your nurses and your health departments are getting paid in comparison to like nurses in across the state. So yeah, thanks for letting me plug that for nurses.
Thanks, Lee. So now we have the occupational health and safety specialist SOC code. So some of the positions that we classified here were the sanitarian, registered sanitarian, sanitarian in training, and then again, that environmental health specialist / sanitarian. As I had talked about previously, that was because that sanitarian piece was in that higher wage bracket. So that's why we classified that in this SOC code. So looking at the graph, again, this one actually, most of the counties are paying under what that OEWS wage is. And if you look at it, you can also see down here that there's fewer counties than the previous 2. That's because we did have 17 counties that reported a position that fit into this SOC code, but only 12 of them had provided us with wage information. And because of that, that's why there's only 12 counties included here on our graph, because they're the ones that provided us with the wage information. And so now, oh no, you're good, Carrie. Now moving on to that social and community service managers SOC code. Again, this is our program managers. So we classified program and grant managers into this, public health managers, health promotion supervisor, a WIC program manager, as well as a nutrition unit manager. And a few key takeaways from this slide is looking at this graph. We can see that there's about half of the counties that are paying under that OEWS reported wage and half that are paying above, which is a little different than the last couple of slides we've seen. Again, many of the program managers that we classified in this SOC code are located in the larger health departments. And then there is a large range in salaries, as you can see looking at our graph. And this is in part due by some of these smaller counties that we have paying a lower wage, which had an outlier effect on our data set.
Okay, good.
So for our medical and health services managers, this is our program directors and our lead local health officials. So looking at this slide and some of the key takeaways, you can see, again, all but 4 counties were under that OEWS reported wage. But it is important to know, as Lee had mentioned when she was talking about the registered nurses, that the OEWS survey doesn't just look at public health. It looks at all of the health related fields. So this is not just including public health directors, but it's also going to include hospital managers in the healthcare setting. And for our report, we only collected wages in the public health sector. So there is quite a bit of a discrepancy when we look at our wages compared to that OEWS. And I think that it's just important to note, looking at this graph, that it does a really great job highlighting the comparison between wages being offered by the public health sector and healthcare employers. Because as we can see from our table or from our graph, the lowest paid health director is making half of what all other positions in this medical and health services managers SOC code would make according to that OEWS reported salary. And then, oh wait, I still have a little bit more to add, sorry. Then just lastly, looking at our average and our weighted average that we have here on this slide, you can see that there's almost a $2 difference here on this table, whereas the other ones, they were much closer. And then I just wanted to make note that this $2 difference is because we had multiple positions that had higher wages within a few counties, which is why the weighted average is reflecting a few dollars higher than the average. So now I'll turn it over to my colleague Alexis, and she'll describe the last 4 for you guys.
Thanks, Portia. Medical secretaries and administrative assistants. Some example titles that we put into this position is lead administrative specialist, administrative receptionist, office assistant, and others like that. Admins in public health often do a lot of tasks, and this could explain why they're getting paid a little bit more, especially in bigger counties. Looking at the average hourly wage graph for medical secretaries and administrative assistants, we can see that the counties reported that their wage is above the OEWS wage. We do have an asterisk here under Frontier, because this is a county that only had reported 1 position, and we didn't want to disclose what that person's wage was. Community health workers. We put quite a few titles into this position based off of the OEWS SOC job description. Some example titles that were put into this category are WIC nutrition aide, counselor, community engagement coordinator, community health worker, and others like that. From what we can see in the table here, community health workers' hourly wage is below the OEWS besides that 1. One thing to note is that hourly wage is higher in the medium county compared to large, and this is probably because of Bighorn County is the only county to pay above the OEWS range, which could be why this average was brought up. And again, with the asterisks on that last one. healthcare social workers. Some example titles that were categorized into this position are case manager, social workers, home visiting care case managers, public health social workers. We also put most social workers under the healthcare social worker based off of the OEWS, and wanted to note that the behavioral health positions were placed under 21-1018, along with other titles like substance abuse, behavioral disorder, and mental health counselors. Not many departments have designated counselors, so a lot of social workers are performing these tests that behavioral health workers do. An interesting thing to note here is that all healthcare social workers positions exist in the large counties, besides 2 positions, one in Frontier and one in Medium. And as you can see on the graph, the average hourly wage for the healthcare social workers reported to have below the OEWS, besides in the 2 counties. And another reminder there for the asterisk here shows that we didn't want to include those positions' wages. And finally, environmental scientists and specialists, including health. Some example titles that we put into this category are water quality protection district supervisors, water quality specialists, outreach coordinators, environmental health specialists. I wanted to note here that the SOC code is different from the environmental science and protection technician's position. We'll go over this again later. We excluded people like sanitarians and other environmental technicians from this specific group and put them in that one, just based off of the OEWS job descriptions. As you can see in the graph here, the average hourly wage for the environmental scientists and specialists reported wages below the OEWS average. And again, noting the asterisk here. And I will pass it off to question times. Please raise your hand with Zoom reactions, or mute yourself if you have any questions at this moment.
I can't believe there aren't any questions from this very active group of folks here. Love to hear your questions at this point. And hopefully you're getting the information that you came for. Well, should we move on, Lee, to talk about tiers of responsibility?
Absolutely.
Right.
Yeah, and just if questions do come up, put them in the chat. And then we will also be doing some breakout rooms, which will hopefully give you a chance to digest some of this material and we can have some more in-depth conversations in those breakout groups. So one of the areas that we wanted to include in our study is the tiers, the 3 tiers, and some of you might be familiar with the core competencies for public health professionals. And this was updated in October of 2021. And in this document, they break down public health workers into 3 different tiers. So the first is our frontline and program support responsibilities. The second tier is program management and supervisory responsibilities. And the third tier is the senior management and an executive leadership responsibilities. But we wanted to go a little deeper. So if you can advance to the next slide, Carrie. So you can see on our data collection tool that we broke it down and asked you all about supervisory roles and program management roles. And interestingly, in our pilot tool that we sent out to 5 different health departments, we ranked them just as tier 1, tier 2, and tier 3, and asked all of you to put that into these job titles into one of the tiers. But what we found unanimously was that it is very challenging trying to figure out which tier some of these positions fit into. So we opted to break down and ask in a different way. So does this position have a supervisory role? Yes or no? Does this position have a program management? Yes or no? And so essentially what we were doing was diving a little deeper into that tier 2. So yes, here we go. So ultimately what we came up with was tier 1 stayed the same, and these people do not supervise personnel and they don't have any program management or responsibility. And you can see that the number of positions that we analyzed, 285, is really the bulk of our public health workers, and which is wonderful to see, because these are just the folks that are doing the work, interacting with our populations. And then the tier 3, we didn't dive any deeper into. We had 36 job titles or job descriptions that fit under the senior and executive management responsibility, which I was trying to go into some national data to figure out if there was an expectation of how many we would have expected between tier 1, tier 2, and tier 3, but unfortunately I couldn't find that definitively. But you would think that, you know, there's going to be less executive management folks and more in that tier 1 and tier 2. So then tier 2, we broke down essentially to see, okay, if they're supervising but not doing program management, if they're doing program management but not supervising, and if they're doing both, they're doing program management and they're doing supervising personnel. And that's how we came up with our tier 2A, tier 2B, and then if they're doing both, tier A plus 2A plus B. And you can see that we have, if you add up all of the tier 2s, again, we've got less than the 285, but definitely more than the 36 folks that are in the tier 3. So what we wanted to find out is if you are taking on more responsibility, i.e. you're a tier A 2 plus B, that you would assume that would increase with wages. So you can go to the next slide. But this didn't always work out. So you can see in the red box that it didn't always indicate that with more responsibility came higher wages. And I think the nurses are a really interesting example, where we've got tier 1 nurses who are going to be more of our frontline nurses, entry-level nurses. They are actually making more than by far the tier 3 and even some of our tier 2 nurses. So to be honest, we don't really, we have no idea why these data show this, but we just found this very interesting and something to consider for future research even. Again, the program managers, we have some falling under those tier 1, the tier 2, which is they're supervising but not doing program management. Again, their wage is significantly lower than the tier 2B. So this might sound, it sounds kind of confusing, but really what we were trying to do was dig a little deeper to ask that question: with more responsibility, does that indicate a higher wage? And as we can see, that was not always the case. I think you can go to the next slide. Okay, so we're actually getting close to the end of our presentation of our findings, and what we came up with 6 key findings, and I'm gonna hand it over to Carrie. She's going to talk about the first 3 key findings, and I will and then I will follow up on the second key findings. We do have a couple questions. Nursing assistants line empty. Why? And I'm not, was that in one of my slides? Maybe we can go back and can you say more about your question?
Just asking Jovina to clarify her question because I wasn't sure what she meant.
Okay, all right, okay.
Oh, you're wondering about why we don't have nursing assistants in the nursing, that why we didn't show that. Is that right?
Ah.
Is that your question, Jovina? Nursing assistants, and I'll tell you why. Nursing assistants actually is in the report, but it didn't show up as a position in the top number of positions that we looked at. So if you look on the report, Jovina, nursing assistants are addressed on page 33 of our report, the public health report. So go to that report, very top of the chat, and look on that page, and then you'll be able to get a little more information about that.
Great.
Thanks for your question.
Great question. And I think that's a good point, is that we overall categorize 30 different positions. We've highlighted 9 of them here. So.
Right, exactly. Let me just first talk about the fact that we had a 50% response rate. And when you go to the mall and you go shopping, 50% off is, oh, that's a great deal. But when you're doing assessments and surveys, when you only have half of the population respond, it creates some challenges in interpreting the data. And the main issue is whether or not people who didn't respond would respond in a similar way to those that did respond. And I wanted to just talk about why we think that the response rate was what I would classify as low. And we hypothesize, and you guys can probably tell us a little bit more about why we had half of the counties didn't respond. But we expect that it has to do with time limitations, and especially around being around the holidays. We started collecting data in November and went through the new year. We talked a little bit about how there was other surveys and assessments going on at the same time, and people get survey fatigue. They just get tired of doing surveys. And we also know that people were confused, like maybe I already filled out that survey. And certainly when Portia and Alexis were calling folks, they heard that, like, wait, I already did that. And we look at our data, say, no, we don't have your response. So it was confusing. And I think people were not sure whether there was utility. Was this worth their time? And I think there was some reasonable reluctance to share individual salaries, especially in small health departments. And there was, I think, some questions about how the data were going to be used. In this particular, because we collected data by health department, so we're pretty sure that most of the positions within the health departments who reported all of the positions. And this figure just repeats the fact that we have data, higher percentage of participation by the larger health departments. So our data is well classifies the large health department salaries, and then as the health departments get smaller and smaller, it's probably less accurate. And importantly, we do not have any data from the tribal health departments, and I think there's probably many reasons why that might be the case, and good reasons why they chose not to participate. Because we sort of know then what we don't know. So if you do individual surveys, you kind of don't know what you end up with. But in this case, we do have an idea of where our data are fairly accurate and where it is less accurate. It'd be interesting to repeat this study in the future to see if people found it useful, they heard more about it, and likely, I would guess, we would get a higher response rate, especially if we fix some of the problems that I mentioned before. So we've talked about a little bit about the fact that some of the positions were not easy to classify. And we talked some about environmental science, and there was really 3 categories that environmental health science positions could fall under. It could be the environmental science and protection technicians, which is actually a title we haven't talked about yet, or we won't talk about because it didn't have as many positions. It could and it could be classified under environmental science and specialist or occupational health and safety specialist. And we talked about the standardized definitions for each of the categories. That's really directed how we classified each of the health department positions. And that's just the definitions there. And in a way, what we're doing was qualitative coding, right? So we have job descriptions, and we're figuring out how they fall into various standard occupations. And then here's some of the public health job titles that sorted out into the 3 different ways that environmental science positions were classified. So how might we be able to address this in the future? One, here's just some brainstorming ideas that public health position job descriptions could link to the standard identifiers that are used across the nation. And that would certainly help facilitate wage comparisons. And I understand that there are some health departments that are in Montana that are starting to do this. In Montana, we could standardize job titles and job descriptions across health departments. And we could develop some consensus about how to classify position titles into the standardized classifications. And how we tried to do this is we tried to be just absolutely as transparent as possible on how we classified job titles. So we have an appendix C in the report that lists every job title and how we classified each job title. And that might be a good place to start. Finally, we could advocate for the feds to include more public health positions in the standard occupational classification system so that public health could have more information about how to classify their positions. And Jobina asked a good question about one of the positions that standard occupations that we didn't talk about. We only talked about 9. And that doesn't mean that the others aren't important. Of course, they're important. But the fact that 89% of the positions in this study were classified into 9 standard occupations really provides public health in Montana with the opportunity to focus in on these 9 positions and advocate for change. And if we were to change salaries and conditions for those 9 standard occupations, it would have a huge impact on our local public health departments. So we also could take the opportunity to really understand how those positions are best classified as well. Let's see, Lee, you're going to talk next about the fact that we had multiple jobs, multiple positions that fell into different categories.
Yes. So yeah, the 4th key finding that we'll talk about is that, and Portia alluded to this earlier in the talk, is that many of our public health jobs, folks wear more than one hat, and we hear that a lot. And I think COVID really broke that open when suddenly, as you know, as the director, you were wearing many different hats, or a nurse was doing many different things. And so that was one of our challenges, was that how do we classify these folks? And like Portia said, they would be classified into the highest category, the highest paying SOC code. So I think if you want to go to the next slide, Carrie.
Sorry.
Yeah.
Doing something else.
Yeah, we found that about 10% of all the positions, so about 50 out of 521 positions, included 2 or more distinct positions. And like I said, many of these included the nurses, the directors, the emergency preparedness folks. And again, more functions require more skill and a higher level of training. And again, we would anticipate that that might include higher wages, but it didn't always happen. So this, again, it would be a really interesting area to explore in the future, is nailing down those positions that hold wear many different hats, and figuring out a better way to classify them to make sure that they're getting paid for all of those responsibilities that they have put on their plate. So I think, yeah, that was number 4. And the next finding that we had was that the salary doesn't necessarily increase with a higher tier. And this just reinforces what I was mentioning earlier, is that you can see our tier 2, especially the tier 2B, their wages were quite a bit higher than even the overall tier, the folks that do supervising and that manage programs. Now, interestingly, if we had decided not to break down the tier 2 at all, it would be a nice, gentle slope up, meaning the tier 1s would, their wage would be average to $25. And this is the average of all the positions that we examined. So if we hadn't broken this down, it would be a nice, gentle slope up. But with that breaking down of the tier 2 and really examining the different responsibilities, we can see that there is a bit of a disconnect. So again, great opportunity for discussion, diving in like, well, why is this happening? And is there a way to tease that out to ensure that folks that are have more responsibility are getting paid a little bit more money? And finally, I think the most interesting finding that we had, so I just wanted to reiterate that sometimes when there was an increase in responsibility, i.e. tier 1, tier 2, tier 3, we saw that increase in wage. And so, for example, community health workers followed this trajectory very nicely. But as I mentioned earlier, registered nurses are some of our program managers, i.e. social and community service managers. It did not follow this at all. And so, one of the one thought that we sort of surmised as looking at the nurses is that some of the new nurses that are coming out are asking for higher wages. And maybe that's why those tier 1 entry-level nurses are making a little bit more as they're coming out and they're asking for those higher wages, or they're entering into a higher paying position. Whereas our folks that have been in the health department for many years, that wear many different hats, their wages just haven't kept up with some of the newer entry-level nurses. So, but we have no research on that. These are just sort of thoughts that we have discussed as we discovered our findings in this study. So. And finally, I think the 6th take-home message is that the majority of our wages in public health are paid, majority of our public health workers are paid less than their counterparts in Montana. And that is goes right to this comparison of the OEWS for a specific SOC code, and then what we found from all of the wonderful materials and jobs that you sent to us. But that's, and when we did all the numbers, 76% of our workers are paid less. And I will refer to appendix, I think it's appendix B in the report. And there's a very nice visual. So anybody, any position, and we list all our 30 positions, any position that came in on average under the SOC, the OEWS, has an orange down arrow, and anywhere the majority are above the OEWS has a green up arrow. Those with the X indicate that we had either not enough data to analyze that. But you can see, what you'll see is that many of our positions are paid less than our counterparts in these SOC codes. And I will just add that any of the positions with the plus mark next to it, that's one of our 9 positions that, like we talked about earlier, is that, we found that the majority of our positions fall under 9 categories, and that's what that plus mark means. And again, you'll find that the majority of our 9 positions also come in under the OEWS wage, reported wage for that SOC code. So I think with that, we have some great talking points on these data that we have compiled and put together in this report. And like Alexis said earlier, I just want to thank all of you for submitting the tool and participating in this study. We couldn't have done this without you. And if we did miss your county, we want to greatly apologize. We want to make sure that, if we were ever given the opportunity, I think, having just ensuring that everybody that wants to participate can participate. And thank you, Carrie, for recognizing Jenny's comment there in the chat. And so I think at this point we are open for questions, and we're really doing very well on our time. I think we are about 4 minutes. We've got 4 minutes, and we're going to take a break, or we can just take our break, or we can take questions from folks. So love to hear your comments. And if we don't get any questions right now, what we can do is, my clock shows 10:56. So should we come back at, Todd has a question. So go ahead, Todd. Thanks for raising your hand.
Oh, thanks, Leah. It's not really a question. It's more, I put a note in the chat, but it's more for you guys and for us here at DPHHS on the response rates. I think next time we do this, and I'm hopeful we will do another snapshot in the future, so we can have like cross-sectional points in time to know if we're making any progress. But I think we can do a lot more working with you guys on promoting with the locals, and particularly the tribal health departments and the frontier and smaller health departments, to get a better response rate. So just a note for you guys and for myself that we'll be glad to work with you guys on the marketing end of this. And if we need to do calls to the locals to ask them to participate, even that we can do from our end as well. So just wanted to say that. And thank you guys for all the analysis. And this, I think we're going to talk more about it, but there's a lot of really good data that, even with the data we have right now from this study, it's super helpful, and it will help us move us in the right direction. So we appreciate it.
Thanks, Todd. Thanks very much.
Yeah, and I think just, after everyone is reassured on how the data will be used and useful, I think that'll make a big difference too. So great to have the state as a partner in collecting the data. Excellent. Shall we go on break and return at 10 after?
I think 10
I
after
have
sounds
something
perfect.
to
yes.
add. So this is Leanne with Daniels County Health Department. I've got provider meetings at 11:30, so I might not make the breakouts, but I did want to mention why, kind of what happened with ours at Daniels County was, how Leah talked about multiple hats. Taylor had me at health promotion specialist, which was what I was when I started, and what I go by when I'm in the schools and doing worksite wellness. But I also have the cancer screening program. I'm head of the program manager for the chronic disease, and manage and supervise 4 different people. And then I jumped to the communicable side too. So I know that was hard. This also went out to the commissioners. We got dinged on that. And one of our commissioners came up and said, how come none of the small and frontiers and, participated, and I went and reached out to some of them that I know did, because I knew the answer, but I wanted it in writing to present to our commissioners. And the most of it was they couldn't find, there just wasn't one category that, their people fell into, and they felt that they couldn't do it justice. So maybe next time, you know, if you had a call like this, it kind of explained it more, and just the highest paid maybe position or whatever, or you know, whatever, that's what we should put in. That might help. I know we're still in a fight with our commissioners for wages because we did come at the lower end, and that's with being in the wrong category. Imagine how much lower we are in the other one. They're not really taking it to heart, this as well, but I'm hoping it's supposed to be presented at Mako, so in Butte. So I'm hoping somebody there can maybe get through to a couple. We'll see. But I just wanted to give our kind of what happened on our end, and that seemed to be the Frontier and the Smalls that I talked to. There was probably about 3 over in our area that did not participate, and that was why. We just wear multiple hats, and they didn't feel comfortable, you know, putting it into one, and it was.
That was such a challenge for us to figure out what to do with these multiple jobs. And I think the smaller the health departments, the more likely that is, right? You have to wear multiple hats. I wonder if we should really figure out how to almost allocate out different SOC titles to that same position. Maybe you can help if we do get a chance to do this again. Maybe you can help us figure that out. That'd be great.
Yeah. And I think you're not alone, Leanne. I think there's definitely a lot of folks in this same boat. And again, like you said, many of the frontier counties were just reluctant to respond. And so that makes it hard for a comparison. I think, it's a tough one for sure.
Okay, so should we go ahead and take a break and come back at 10? How about 11 after?
11 after. Okay. See you guys in a few minutes. All right, welcome back, everyone. It looks like it's about 12 past. So in this next part of the presentation, we're going to break out into groups. I think we've got 4 of us, and so I think Desiree is... Go ahead, Carrie.
Sorry, Lee. Yeah, I just want to say that how nice it would be if we were meeting in person. Wouldn't that be nice?
Yes.
We could sit around and have a discussion, and that would be, I'd love to have that. But of course, here we are, all on our little screens. I want to just go through the brainstorming questions that we have for everybody. And Alexis, can you put the Google Doc in chat? Yeah, I can't turn my camera on. I know. I don't know how to do it right now, but I will figure it out. I made myself go away. So we're going to talk about, these are some of the prompts. What did you find surprising or interesting? And then a lot about how people have used the report or how they think they might use the report. And we hope that people can share some resources. And we're going to go ahead and, we're going to go ahead and use a Google Doc so that we can all see the ideas that are generated from the other groups. And then we'll come back together and share some of the GEM ideas. So Desiree, do you want to talk about how you've grouped us, and we'll go from there?
I am using the magic wizardry of Zoom. So Zoom is just breaking everybody up into 4 separate groups. And then each of the co-hosts will jump in one of the groups. So when you're ready, let me know.
I think we're ready.
Okie doke.
Have the magic happen.
See you back here in 20 minutes.
Yes. So Alexis, is your group ready to do a little report? All right. But let's just wait at 32 seconds.
Okay.
If you could, please.
Looks like you had a busy group.
Yeah. It's spelled dietitians.
There we go. So Todd, have you led some training on how to use the report in with the local health boards, or how to discuss salaries with local health boards?
Hey, Carrie, was that for me?
Yeah, sorry, Todd. I
Oh.
think, yeah,
No, yeah, I would say no, not any trainings or anything. We've done kind of one-on-ones with selected counties who are trying to work on the issue, and then had discussions about how to present the findings, kind of summarize it so it's easy to understand for boards of health and commissioners.
yeah, great. So we're out of breakout rooms, I think. Let's hear a little bit from group one, especially some of the key takeaways, the nuggets, some things to share with the rest of the group.
I'll share for our group. One of the big key takeaways I thought was interesting, hearing from Kelsey at Bighorn County, that her thoughts on that, why they did well having higher wages, is probably because they most of their positions used to be under the hospital until the county took over. So when the county took over, they just kept those wages, and that probably was a big advantage for why they had higher salaries.
Okay.
Another big thing that we theme that was talked throughout was how we have these conversations with commissioners, that they're the decision makers, and how we can use this and the art of talking to them and letting them know what is found, and that this was a good baseline of getting. We already knew that salaries were lower compared to other positions, and so this is a good report to like have concrete proof that this is real.
Okay.
If there's anyone else from group one wanted to share anything, go ahead.
Portia, what were some key takeaways from group two? Or is someone else from group two wants to report?
I can kind of share, and then if anyone else in group two wants to add in, they can. We talked kind of a lot about how the county commissioners are the ones that are setting our wages, but don't really have any idea about what public health officials do. They just kind of think that we're just doing immunizations and that's all. So why pay for more than just giving immunizations? So that was kind of one of the things that we kept coming back to. And then also, you know, our report kind of looked at like comparing the wages across counties, but for some of the county health departments, they're not competing with the regional health departments like their county commissioners think. They're competing with the hospitals or the other health service fields in their area. And so that was kind of one of the things that we talked about. And I know as a research team, we talked about how a future study would be really helpful in kind of comparing the two if we had time to do that. And then just the biggest takeaway was I had asked if they had found any other resources that were useful. And they said that they didn't have time to look because they're just taking everything on with their health department. So they were just really grateful that we went ahead and conducted this study and interviewed them and gave them an opportunity to talk with us because they have a lot to say on the subject matter and their county commissioners aren't necessarily listening to them on it.
Awesome. Lee, your group did such a good job following directions on the Google Doc.
Our group was wonderful. I got to meet the two new workforce new hires at DPHHS, so that was wonderful. And then we also had Anna Semple from Missoula City County Health Department, and Jen Tollefson joined us at the very last, so we got to get that perspective from the frontier, a frontier county. So I think, can you scroll up so I can look at my notes, Carrie?
Sorry, I was just trying to get complete.
Interestingly, well, one of the things that Holly mentioned was that she was thinking how this could have been worse if we hadn't had all the funding that came from the federal government. For example, the ARPA funding. And my question, or that, you know, the discussion we had was, some of that might have trickled down into our salaries reported, but some of it probably hadn't, because some of that money was still getting dispersed. And so that's where, you know, doing a snapshot in a year or something would be really interesting to see if some of those funds have made any differences. The other, and again, just ensuring that those funds get into the hands of the workers. Anna's made the point that the concept of people wearing multiple hats felt very real, and the challenge of categorizing those folks into specific job codes. And it sounds like Holly does have some experience using some of these SOC codes. So that was a great connection there, I think. And then the other thing that Anna mentioned is how, you know, it would be interesting for some of the union reps to see this report. Because, you know, we really stayed away from we didn't go down, you know, this report doesn't have anything to do with any unions or anything, but where that would maybe be interesting for employee advocacy, especially for some of those larger health departments. And then the other thing that came up was looking at what other states are doing. And I think we can safely say, as the team, we researched pretty heavily other salary studies like this for public health, all, you know, nationally, and we didn't find that much. So, but it would be interesting to see what other states are doing. And then, of course, Jenny was very hopeful about using this report, again, talking to her county commissioners, because she feels like her wages are quite a bit lower than in other frontier counties. So I don't know if any of my group wants to add anything, but it was super great to meet the new folks from DPHHS. So that was fun.
Awesome. Anything else from group 3? All right, group 4, we Deb was there, and Allison. Well, I was there, and I was there, and let's see. Remind me, Allison, who was
and Leanne.
Leanne was there. And then I think maybe one of the most interesting things that I heard was that that Deb talked about this strategy of kind of using the report as she called it a buffalo strategy. She doesn't have a mic, otherwise I'd have her unmic and share that with you. But basically this idea of telling the commissioners that these data are coming and we're going to be on the very bottom of the pile, and they were motivated to get out of the bottom of the pile. And so it was, I would say, a strategy of basically saying we're going to be embarrassed publicly, and they didn't want to be publicly embarrassed to have such low salaries. So that was certainly an interesting approach, I think. And Allison made a good point that, you know, getting together with some of the smaller health departments and tribal health departments and thinking through what some of the issues are, like multiple hats, would be useful in addressing some of the concerns that people may have had about providing data, and whether they could provide data that would be useful and accurate and reflect appropriately on their in their county or tribal health department. And Allison, anything else? I know Deb doesn't have a mic and Leanne had to jump off.
No, nothing to add from me.
Okay, awesome. Well, I think we got some ideas of how people have used the report, and it sounds like commissioners are clearly the one of the main audiences. So I guess one other thing that came to my mind when I was meeting in the small group is the idea of creating county specific reports and how that might be useful instead of, a report that's really designed for the whole state to pull out data specific for counties. That would be a big endeavor, but might be more useful and usable for people who are not spend a lot of time digging through a report. Yeah. Okay, good. So that wraps up our presentation today. And Lee and I's contact information is on the first couple of pages of the workforce wage study. And we would certainly welcome you to reach out and talk more about any questions that you might have. And I think with that, we will say goodbye and thank you for joining us. Desiree, I'm going to turn it back to you to end the Zoom.
Thank you, ladies. This was a wonderful, wonderful presentation. And, I learned a lot, so I'm hoping everybody else learned just as much as I did. I have left an evaluation link in the chat, so please, if you have time, quickly take the time. Just kidding. Please take the evaluation. And with that, we thank you for joining us today, and we'll see you next time. Thank you, everyone.
Bye.
Thank you so much for this presentation. You guys did great.
Nice to have you.
Thanks, everyone.
Bye.
That was
I
good.
don't know, team, do we need to debrief at all?
I think that was good. We had a really good turnout, which was nice. It seemed like most of the people that had registered were there.
Todd, I see you're still with us. Is there anything you want to comment on, or Jenny, or maybe you're just in another meeting and your Zoom is open?
Nope.
Oh, you're muted.
Sorry, I'm just doing the evaluation. I'll leave so you guys can talk about us. But hey, just want to say thank you, for the work on the study, and then this training was super helpful. And if we can get the link or whatever way we can share it with the lead locals, I'm sure a number of other people will listen in and watch it as well. So appreciate you guys all the time and effort. So have a good day.
All right, thanks, Todd.
Thanks, Todd.